To welcome you all to our first wave of women empowerment program, training program. And I would like especially to thank my dear friend and colleague, Professor Dr. Nada Domyoti, for all the great efforts she has done to make this come true. This was a big dream, and now it's coming true by the hands of our friends, colleagues, our professors and our mentors, and also by the aid and the participants of our international guests who didn't hesitate to help and support. And I hope this will be a great scientific day for everyone, all our trainees and all our great professors. Now I will speak about how to master the basic colonoscopy. We were sure during preparation of this program to make sure that the basic endoscopy skills can be assured. Everybody needs the advanced techniques nowadays. Everybody's seeking the great advances that are happening around the world, but we are sure that we need to make sure that our trainees know very deep in the basics. So we will go to the very basics of colonoscopy. Colonoscopy is an essential tool, the gold standard to examine the large bowel. So many advances in colonoscopic techniques emerged due to the need for screening, surveillance, and diagnosis of cancer colon. And this has aided in addressing the treatment of many colonic diseases through various complex therapeutic and interventional techniques. If I go through my agenda, will be about the indications, the preparations, the observations, the techniques, the quality, and the advanced learning tools. So it's not only about the techniques. The techniques just is one point. If we go through the indications, which is a very important parameter in requesting colonoscopy from our patients, we need to go through this very thoroughly and very carefully. The patients who suffer from lower GI bleeds, of course, he needs a colonoscopy. Patients who are subjected to screening and surveillance of colorectal polyps and cancers. Patients who are also post-resection of CRC. Patients with inflammatory bowel disease. Patients who are waiting for therapeutic indication for colonoscopy, they have been diagnosed with something and they need to either treat the bleed or excision or ablation of a lesion for colonic decompression, dilatation of stenosis, foreign body removal, or otherwise any abnormalities with the colon, such as radiological examination, abnormal radiological CT or MRI, isolated abdominal pain, chronic constipation, chronic diarrhea, and intraoperative or perioperative localization for a lesion. So the first step after requesting a colonoscopy for an indication is how to prepare this patient for a colonoscopic examination. And this is a very vital step. Without it, the quality of the examination will be subjected to many questions. So the ideal preparation for colonoscopy should reliably empty the colon of all fecal matter in rapid fashion with no gross histological alteration. So it should be with patient comfort. It should be safe, convenient, tolerable, and inexpensive. Effective patient education significantly improves the quality of this bowel preparation. So you need to spend some time with your patient describing exactly how to perform the bowel cleansing. So patient counseling with written and verbal methods, visual aids, educational booklets. Sometimes we use smartphone applications. So the regimens always incorporate dietary modifications along with oral cathartics. A clear liquid diet is advised 1 day before. It should be could be allowed until 2 hours before the procedure. Red liquids should be avoided, and you should make sure that the patient has adequate hydration during the period of the bowel preparation. Also, split dosing proved to be very effective in increasing the adenoma detection rate. Split dose is giving the bowel preparation dose on the same day as of the colonoscopy in 2 split doses. If you are performing the colonoscopy, for example, tomorrow, then the patient will take 1 dose the night before and then 1 dose in the morning if you are doing it afternoon. And if you are doing it in the morning, he can split the dose the day before. It is very important that the bowel preparation be documented in the colonoscopy report, because this will apply on how good you examined this colon. So it should be documented. Various scores are existing to document with. Bowel preparation should also be individualized for each patient, prescribing provider of each patient based on the efficacy, the cost, the safety, the tolerability of various solutions, and also the comorbid conditions of the patients. As we said also, it should be with verbal counseling, and you should take your time and spend it with the patient to make it proper. A low residue diet is recommended for also the preparation before. Sodium phosphate and magnesium citrate preparation should not be used in elderly patients. It is also recommended that endoscopists document the quality of the bowel preparation. We have said that before. And if a patient with inadequate preparation should be offered a repeat colonoscopy within 1 year. The next step, after I have already cleaned the bowel and I'm sure that the patient is now ready for colonoscopy, is how to get into the training system for performing colonoscopy. So colonoscopy training begins with observations. As much as I observe our seniors in the endoscopy unit, this is how much I can learn about the imaging and about the disease and about how to diagnose a lesion and how to perform. Learning by watching is very important step in learning colonoscopy. And then you start performing colonoscopy without assistance of the senior after some period of examination, of observation. This study was published in the GUT 2010, and it shows that it was aimed to determine the colonoscopy learning curves and factors associated with this difficult procedure at a single center. And they showed that the minimum number of procedures to reach technical competence was 200 colonoscopes. So, and the cecal intubation time was longer in females and older patients in this study. So as we see here, the curve increases, the success rate increases with the numbers of colonoscopes as much as you perform. So we see that it reached the maximum after 250. Also, the level of experience increases with lesser intubation, cecal intubation time. The faster you reach the cecum, the more experience you have. This study was also published 2023 about the global trends in training and credentialing guidelines for gastrointestinal endoscopy. And they show here that also the key performance indicators on colonoscopy, the minimum procedure number was 200 according to the UK guidelines, and 2075 according to the American guidelines. The KPIs are also should be unassisted cecal intubation rate more than 90%. Rectal retroversion should be more than 90%. The adenoma detection rate should increase over 15%, and in some papers 20%. Second to learn is also, after watching and observing for many cases, is to know exactly the anatomy of the colon. As we see here, the colon is composed of at least 9 parts, and these will help us also in documenting the colonoscopy during examination. Every landmark of the colon you have to know very well so that you can know exactly where you are during performing the endoscopy. The first picture shows retroversion in the rectal area, and then you see the rectum, the hosturations, and then you see the sigmoid colon, and then the splenic flexure, and then the transverse colon, the hepatic impression, the right colon, and then the cecum, and then when you reach the ileum, you know you are finished. The challenges with the techniques which everybody is just focused on is how to deal with the colon mesenteries. We have colonic mesenteries that cause the looping of the colonoscope during performing colonoscopy, which cause a lot of challenge for all the beginners, and it takes more of time, causes more complications if you don't know how to manage these problems. So the colonic loops are the monsters that we think of when we think about colonoscopy. It can be either in the alpha loop, N loop, reversed alpha loop, or omega loop. What can you do to unlock the loop is carrying the following steps. Withdraw clockwise the torque and re-advance, maintaining the torque. Then you straighten the scope, and then you can reduce the mesentery over the scope, and then you can re-advance freely. Withdraw with anti-clockwise torque and also re-advance again. Then you also have reduced the sigmoid loop a little bit. And then the last thing, if you don't succeed, then you can change the position of the patient to the supine and restart again. The length of the mesentery and extent of retroperitoneal fixation determine the acuteness of the sigmoid and descending junction. The sigmoid colon can be stretched as much as 80 centimeters, and it also can be shortened as much as 25-30 centimeters. So if you straighten the scope, then you will shorten the time and shorten the loop, and then you can advance one-to-one movement freely. You also have to anticipate the altered anatomy of the sigmoid. The colon has very much variable anatomy, so you have to expect different anatomic variations in different patients. It can be very acute, especially in elderly patients with stenosing diverticular disease. You have to be very careful with diverticular disease. Patient with a history of pelvic surgeries, such as hysterectomies and cesarean sections, and young women also. So you don't push forcibly, never push forcibly during colonoscopy through the sigmoid colon, but you torque and then steer and clockwise rotation, and then you reach the descending colon. So if we cross the sigmoid colon, we will have also the difficulty with the splenic flexure. So if you want to reach the splenic flexure very easily, the scope should be very straight by reducing any loop you have. And then the loop resolution technique, if you start and you don't finish loop resolution and you continue to advance, you will have more looping. So it will harden your job if you don't reduce the loop very early. Colonic anatomy may vary considerably, as we said. The most reliable landmarks of the cecum, if I want to make sure that I've reached already the cecum, is the appendicular orifice and the ileocecal valve. This is the sure sign that I am in the cecum. I have done cecal intubation. And don't forget that blind area exists all over the colon, especially at the cecum between the ileocecal valve and the appendicular orifice, the hepatic and the splenic flexures, and also in the rectum. So even some professionals can also perform retroflexion in the cecum or in the some parts of the colon, but only professionals can do it. Don't try it for yourself as a beginner. Retroflexion of the colonoscope in the cecum and rectum are useful to exclude hidden pathology. The next step after I've mastered already the colonoscopy is to take enough documentation by imaging. All the scopes now have digital imaging systems, They can document either by video or by just photos. So you should not waste this. You have many techniques now to use during for your different scopes that are being used in Egypt. So adequate and relevant quality image documentation is necessary, and faithfully document the endoscopic finding. And it is the best method to ascertain that you have completed the examination and also that you diagnose the lesion that is present. You don't have to describe it in your report, but just a picture would document and describe everything you want to say. The EGE released the quality screening colonoscopy position statement, and also another performance measures in upper GI endoscopy was also done with it. And they recommended at least 9 images at specific landmarks of the colon to assure full examination and documentation of your examination. The picture number 1 is in the retroflexion position in the rectum, yes, in the inner rectal area, and then the rectum, the sigmoid, the transverse colon, and the ascending and the transverse and the descending, and then reaching the cecum and the appendiceal orifice. After I documented everything, I have to make sure about performing the quality in colonoscopy, which is a major critical issue in performing colonoscopy. You have to make sure that you reach the standard, the minimum standard of key performance indicators, which are the cecal intubation rate. It should reach more than 90% of the examination. If you didn't reach 90% of your examination to reach the cecum, then you still need more training. Of course, 10% is missing because either you have lesions that stop the completeness of the examination, or you had intolerability of the patient. But 90% or more is enough for you to reach the cecal intubation rate. Adenoma detection rate should be more than 15%. The bowel preparation also quality should be 90% achieved. The retroflexion of the rectum is also needed. And if we go through, the minimum number of colonoscopy to achieve competence is also 200 colonoscopes. Finally, after we have mastered colonoscopy, we need to just learn about the advances in the field of colonoscopic examination. Automatic detection of biological landmarks within the colon is highly demanded, which help reduce the burden of clinician by providing guidance, information, and locations of the lesions. At first, they used to. I'm trying to simply explain how the AI works, or how they generated the AI. It's just raw colonoscopy video sequences and the collection of pictures have been collected and given to the AI machine learning systems, and then they created a library of data about how to diagnose the normal mucosa and the abnormal mucosa and the lesions, and that can make it very much easier for the beginners to learn, and also make it shorter time for the experienced doctors to achieve more credible results in shorter time duration. And they started, this has developed into the CAD-I system, and different systems exist in different brands of the scopes. As we see here, the AI can just detect a lesion and tell you about it, even if you cannot miss it. If you miss it by your eye, then it will give you a guidance to make your time shorter, and then to give you more experience. And it's a big debate now about if the AI will replace the experience and mentors, doctors, and I don't think this is really happening, because I think our mentors and our experienced endoscopists are the ones who teach the AI systems what is correct and what is mistaken. And thank you for listening to me. Our take-home messages today, we will go back to our agenda that we have achieved already. Indications for colonoscopy is a basic knowledge. Preparation of colonoscopy is extremely important and worth the time spent on it. Don't make it speedy or just don't spend time on it. Observations and training should follow international guidelines and number of cases. You have to make sure you have reached full competence before performing colonoscopy. Techniques are very important and you can learn it very easily if you have a good mentor. Quality application increases the skills of the endoscopist, and you need to know more about the AI and the advanced learning tools. And thank you for your listening and attendance.
Thank you.